Good morning, class. Today we'll discuss about the one important neurological condition, that is Myasthenia Gravis. I am your teacher, Dr. Bhupendra Shah, assistant professor working at Department of Internal Medicine at B.P.Koirala Institute of Health Sciences, Dharan, Nepal. So, what we are going to discuss in today's session, we'll define what is Myasthenia Gravis, what is the pathophysiology, clinical feature, investigation and treatment of Myasthenia Gravis. I think you all people know this man. He is the mega star of Bollywood. He is none other than Mr. Amitabh Bachchan. So, Mr. Amitabh Bachchan, and you can look some bit of ptosis in his eyes. I do not know, but he is a patient with Myasthenia Gravis. So, what is Myasthenia Gravis? When we are dealing with any patient with neurological presentation, we have to first make a diagnosis of patient anatomically, whether the problem lies at the level of muscle or a neuromuscular junction or nerve or spinal cord or brain. So, Myasthenia Gravis is a condition where there is a problem at the level of neuromuscular disorder, neuromuscular junction. In between the neuron and muscle, there is some potential space where the nerve releases the one important neurotransmitter, that is acetylcholine, which is required for the muscle contraction. So, Myasthenia gravis is the problem of this neuromuscular junction, which is typically characterized by weakness and fatiguity. In the initial state, patient will complain the fatiguity, mean that they cannot sustain any performance. Okay, like they can walk, but after few hours of walk, they became fatigued. They can lift a hand, but after few minutes of lifting hand, they became fatigued. They can look upward, but after few minutes, they will have the fatiguity in the eyelid. This is the classical symptoms of fatiguity. And the weakness, they will also complain the weakness on the later stage of Myasthenia gravis. So typically, it affects the skeletal muscle only, skeletal muscle. So what is the pathophysiology? So as you people know that there is some potential space here. This is the neurons, this is the muscle, this is the neurons, and this is the muscle. And in the neuron, you can see there are the acetylcholine here. These are the acetylcholine. With the excitation of the neurons, this acetylcholine is released into the synaptic cleft, and this acetylcholine will act upon the acetylcholine receptor in the skeletal muscle, classically called nicotinic receptor. We all know there is a nicotinic receptor for acetylcholine in the neuromuscular junction, and on when the acetylcholine act upon that nicotinic receptor in muscles, the muscle get activated and there will be the contraction of the muscle. But what happens in the Myasthenia gravis is it is one of the autoimmune disease, mean that is a condition where there is a formation of the antibodies against own cell. So the name of the antibodies, the anti-acetylcholine receptor antibodies. There are other antibodies as well, like anti-MUX antibodies, muscle kinase antibodies. So, but most of the time we get the anti-acetylcholine receptor antibodies. Acetylcholine receptor. So these are the receptor. Okay. So these are the receptor. So there will be antibody form against this receptor. When the antibody form, then that antibody will act upon this receptor, and on continuous stimulation of this receptor will become less responsive to the natural acetylcholine, and there is the destruction of this acetylcholine receptor. So, in Myasthenia gravis, there is the destruction of acetylcholine receptors. When there is a destruction of acetylcholine receptor, natural acetylcholine can't act upon that acetylcholine and can't contract the muscle. So, this is the typical pathophysiology of the Myasthenia gravis. So, the one of the proposed hypothesis is that the thymus is the organ which lies just beneath the thyroid gland. They produce the antibody against these receptors. So, the thymus removal is one of the treatment strategy of Myasthenia gravis. So, the, in summary, there is the formation of anti-acetylcholine receptor which destroy the acetylcholine receptor in the neuromuscular junction. This is the pathophysiology of Myasthenia gravis. So, clinical feature. So, we see near about 10 to 15 cases of Myasthenia gravis annually. We don't see much cases of Myasthenia gravis. But in my clinical experience, I have seen patients suffering from Myasthenia gravis of age near about even 4 years, 5 years child. But most of the time I see I see near about the adult patient as well as the elderly patient. So it has a bimodal peak incidence. So like in most of the literature, it said that it is more common in 20 to 30s and also 50 to 60s. It has a bimodal pattern. Okay, so okay, this type of pattern. So, classical feature of the Myasthenia gravis is weakness and fatigability on repetition. Like classically, like when you are looking at a particular object, you don't have any complaint in the beginning, but when you like maintain that staring, then after few minutes, then you have a fatigability and you start having the double vision, diplopia, yes, and then you will have also having the eyelid drooping. So there will fatigability, and similarly, like in the if there is a mm, effect on the pharyngeal muscle, then what happens, like when you go on speaking in the initial, you can speak like okay, and then when my student like that. Now on the repetition, they cannot speak because they will have the fatigability in the pharyngeal muscle after few minutes. When they are chewing, in the initial they can chew the food, but after a few minutes they are difficulty in chewing. So they on the repeated action, they will have the fatigability even in the oral cavity. In the arm, like initially in the morning hour, they are absolutely all right, but as the days passes with activity going on, they give fatigability usually in the evening. So there is a deterioration of the fatigability or weakness usually in the evening time. This is the classical picture of the Myasthenia gravis. Okay, and this condition have frequent relapses and remission. So most of the time what you see, I see the common presentation of Myasthenia gravis I see is the ptosis. It can be started from unilateral, sometimes unilateral, sometimes bilateral, but most of the time it goes from one eye to another eye. Started with the unilateral eye and then involved the another eye. Okay, there is a ptosis, and most of the time, but some patient I have got with the like weakness of the pharyngeal muscles, laryngeal muscles. Sometimes I get the weakness of the limbs as well. And in a few cases, this is a tertiary care hospital, patient directly presented into the Myasthenia gravis, mean that they have the respiratory failure, because even the respiratory muscles are the skeletal muscles, and there is a important like intercostal muscles, like there is a weakness. Even the diaphragm can get fatigue in Myasthenia gravis, and they will have they directly present with the shortness of breath and shortness of breath. Okay, so these are the common presentation of the Myasthenia gravis. So what are the bedside tests for Myasthenia gravis? Near about 3 months ago, so there was a elderly male who presented to me with the ptosis. So, so the simple bedside, after taking the proper history and after doing the examination, you can do simple, very simple bedside test, that is ice pack test. What in the ice pack test, what you have to do, you have to do the cube of ice, wrapping over the gauze piece, and you can put in the your eye with the ptosis, you can put here. And there is the improvement in the ptosis after you keep the cube of ice over that eyelid, because when there is a reduction in the temperature at neuromuscular junction, there is a better transmission of the acetylcholine. So the acetylcholine will can act properly if there is a reduction in the temperature. That is why you can do the ice pack test in the even in the bedside. Okay, this is a very simple test. Second one is we can do the forward arm abduction test. Just you do the forward arm, ask your patient to abduct the arm, and then you ask them to close their eyes, or it is not necessary most of the time. Usually they can sustain for more than 5 minutes, but if they complain the fatigability, if they cannot sustain this forward arm or abduction, then you can say there is a fatigability present, and it like it gives us a clue towards the myasthenia gravis. This one, another test you can do is the upward gaze test. Upward gaze test, like in the first picture you can see here, you see it seems normal, but you ask your patient to look upward towards the ceiling, but after looking for a few seconds, you can see she had developed the ptosis here, she had developed the ptosis, yes, she had developed the ptosis. When she had developed the ptosis here, ptosis here, and you ask them to close their eyes for a few seconds. After closing their eyes, then eyes must this eyelid like get the rest, and like after having some rest, then you can easily open the eyelid. So here you can easily see the fatigability. If you are sustaining the certain performance or doing the certain activity, then there is a deployment of the ptosis, and after taking the rest, there is an improvement in that ptosis. This is what we can see through this the upward gaze test. So what are the bedside? There are other bedside tests as well for the 9th semester student. I think it will be sufficient for you people. You can do ice pack test. You can put the cube of ice over the ptotic eye, and that ptosis will be improved by that ice cube. This is one important test. You can do forward arm abduction test. You can do upward gaze test. These are the simple bedside tests. But most of the time, sometimes we do the we do we you can send the blood sample for to look the anti-acetylcholine receptor antibodies. This we can do, we can assay the level of anti-acetylcholine receptor antibodies by the serum, and most of the time I get the positive report in a patient with myasthenia gravis. Okay, and another test, if we have a facility, then we can get repeated nerve stimulation test. We can repeatedly stimulate the particular muscle by giving the electrode. After repeatedly stimulating the particular muscles and the nerve, there will be the reduction in its response. There is reduction in its response, depicting the fatigability. So this is called repeated nerve stimulation test we can do. There is another important test that we usually do, that is called adrophonium test, in which we give the 2 mg of adrophonium, and that can be given by which is also followed by 8 mg, and we have to look after giving the adrophonium whether there is improvement in ptosis or not, whether there is improvement in the muscle weakness or not, we can see. Okay, adrephonium, because adrephonium is the short acting anticholinesterase, mean that it inhibit the anticholinesterase. When it inhibit the anticholinesterase, there is a there will be the increase in the acetylcholine level. If there is increase in acetylcholine level, then the weakness of myasthenia will improve. Okay, that's why this is the concept of adrephonium test. But why we choose adrephonium? Because it's a short acting, its effect will be short acting, we can immediately see its effect, and and there will side effect will be for only the short period of time. That's why we choose the adrophonium, but it is not available easily in the market. That's why we do with the neostigmine test. We do the neostigmine, but we should be always be aware, because they can have the anytime the can go into the cholinergic crisis, and patient may need the ventilatory support. So most of the time we do this neostigmine test in the critical care setting, okay. So, and one differential diagnosis for myasthenia gravis is Lambert-Eaton myasthenic syndrome, where there is also the fatigability, But the classical picture of limbs is the weakness of the lambert eaton system will improve with activities, so there is also the uh, decrease or increase in weakness, but in the limbs there is the weakness that what the patient complain will be improved with activities. There is the depressed level of reflex, which is generally not present in myasthenia gravis, and there can be also the autonomic dysfunction. Okay, so limbs usually we get as a paraneoplastic feature of different carcinoma, especially lung cancer. We get the limbs as a paraneoplastic feature. It is one of the closest disease of the myasthenia gravis. So, till now, what we have discussed, about the myasthenia gravis is that myasthenia gravis is which is a disease of where is the disease of the neuromuscular junction, and it usually affect the skeletal muscle. So, pathophysiologically, there is a formation of anti-acetylcholine receptor which damages the acetylcholine receptor, so that acetylcholine can't act properly. The clinical feature is clinical is fatigability and weakness, and usually involve the highly active muscles like eyelid muscles. They are each active, but patient can have the weakness at any skeletal muscle in our body. There are some bed tests we have discussed. There are the ice pack test, there are forward arm abduction test we have discussed, and upward gaze test we have discussed. Similarly, the investigation what we can see in the we can see for the acetylcholine receptor antibodies, we can check the repeated nerve stimulation test, and we can also do the adrophonium test or neostigmine test. But when you diagnose any patient to have is having the myasthenia gravis, we should never forget to check the associated condition like thymic abnormalities. In most of the time, we get some form of thymic abnormalities like thymic hyperplasia or sometimes thymoma. We should detect that because we have to treat that condition as well. And second is the thyroid disorder. Most of the time, this myasthenia gravis associated with certain thyroid disorder like hypothyroidism as well as the hyperthyroidism. Okay, hypothyroidism as well as a hyperthyroidism, and they also associated with other rheumatological conditions like rheumatoid arthritis, hematological condition like the pure red cell aplasia. These are the associated conditions. We should be always aware of these conditions, and we have to always work up to rule out or rule in these conditions. Okay, so how we are going to treat any patient with myasthenia gravis? This is the algorithm given in the Harrison. So here they have divided the myasthenia into the three parts. The one important condition is that we have to diagnose it unequivocally. Okay, we have to diagnose this condition because the treatment and drugs have so many side effects, and we should never forget to search for the associated conditions like thyroid disorders and thymoma like that. Then we have to divide into three parts. If patient have ocular feature only ptosis and diplopia, we have to do the MRI brain because there are other causes of the ptosis as well, and to rule out the other possible differential diagnosis if there's only ptosis. And in that condition, we can only give the pyridostigmine. This is the pyridostigmine. This is the anticholinesterase. We can give the pyridostigmine, and with the supplementation of pyridostigmine, most of the time patient improves. But if the unsatisfactory response, we can try the immunosuppression. Second is generalized conditions. Generalized conditions, first of all, we have to try with the pyridostigmine, like if that they have ptosis and they have also the limb weakness, they have some pharyngeal weakness. Then we first will give the symptomatic treatment with the pyridostigmine, and definitely we have to evaluate for the thymectomy. Like if the patient has thymoma or generalized myasthenia gravis, and if patient has the uh, uh, like good force vital capacity, then we can try the thymectomy and the immunosuppression. We can try the thymectomy and the immunosuppression. So thymectomy is basically we do in a patient with concomitant thymoma and generalized myasthenia gravis, and usually if the patient age is less than 55 years, then we do the thymectomy. Okay, then some patient, as I have already told, that some patient directly present in the respiratory failure. In that scenario, we have to give them the respiratory support by like intubating and by ventilating them, and we have to treat the conditions which precipitate this myasthenia gravis. And commonly the different infection and different respiratory infections precipitate the myasthenia gravis, and we have to give antibiotics in that condition as well. But myasthenic crisis is treated by two conditions, two uh, therapeutics. One is plasmapheresis, another is IVIG. Most of the time we use IVIG here, and they response, and then the patient improved, then we can go according, we have to manage them as a generalized myasthenia gravis. And if not improved, then we can try the immunosuppression. So there are three phenomena. If patient come into crisis, intubate them, treat the precipitating conditions, use plasmapheresis or IVIG. That is what you need to know. If it's generalized, use the symptomatic treatment, evaluate for thymectomy. If it's ocular only, try the only symptomatic treatment. This is how we are supposed to treat a patient with myasthenia gravis. Then the pyridostigmine is the anticholinesterase medication. So anticholinesterase, it inhibits the cholinesterase enzyme. So if we can inhibit the cholinesterase enzyme, there is a high level of acetylcholine, and that gives a symptomatic benefit to the patient. That gives a symptomatic benefit to the patient. That's why pyridostigmine is a common drug that most of the patient with myasthenia takes. That is, the dose of pyridostigmine is 30 to 60 mg, and we can give 3 to 4 times daily. And thymectomy, as I have already told, we have to give thymoma, and in all patients of generalized myasthenia gravis, we should always consider thymectomy, and we have to take the help from our CTBS surgeon for the evaluation of the thymectomy. The immunosuppression, like if someone has the generalized myasthenia gravis, if they are not improving with the symptomatic treatment with pyridostigmine, then we have to try with this immunosuppression with steroid like prednisolone. The difference of starting prednisolone in myasthenia gravis in other condition is that usually start with low dose of steroid. Like we start with a low dose and we increase every 2 to 3 days by 5 mg. So most of the condition we use high dose of steroid and we taper, but here we start with the low dose and we increase by like 5 mg every 2 to 3 days. Why is that so? Because if you give the student high dose, that can even precipitate the myasthenia gravis. So we are not supposed to give the prednisolone in high dose in the beginning. We have to see the response, whether the patient improves or patient deteriorates. Then we go on increasing. Okay. Then other immunosuppressives that we can use are mycophenolate mofetil, azathioprine, cyclosporin. These are these. But most of the time I use azathioprine or mycophenolate mofetil while managing a patient with myasthenia gravis. So this is the treatment modalities that we can use when they are in crisis. That is plasmapheresis and IVIG. Most of the time we use IVIG here, and this is for the rapid improvement in the symptoms. Rapid improvement in the symptoms. So take home message for this today's presentation is myasthenia gravis is a disease of the neuromuscular junction where there is the loss of the acetylcholine receptor due to the formation of anti-acetylcholine receptor antibodies. Most of the time these antibodies are like formed like produced by the thymus gland, and the clinical features are fatigability. Most of the time the fatigability occurs at the level of the eyelids and the extraocular muscles. And there are different bedside tests like ice pack test, forward arm abduction test, upward gaze test, and other tests like we can assay the anti-acetylcholine receptor antibody. We can do repeated nerve stimulation test. We can do adrophonium test or neostigmine test. And treatment that basically depends upon the type of myasthenia. If it is ocular only, then we can only try with anticholinesterase medications like pyridostigmine. If it is generalized, we can try with pyridostigmine. Then we have to evaluate for thymectomy. It is crisis, then we have to treat them with plasmapheresis or immunoglobulin. I think for today we'll conclude here, and if you have any comments, any confusion, you can write in a comment section. I am here to help you people. Thank you so much for your attention and concentration, and please share the video to other students as well. So life is similar to boxing ring. Defeat is not a final. When one falls down, it's a final. When one refuses to get up and fight back. So always fight back, always enjoy learning. Thank you so much.